Oh, good morning, good morning. Welcome to a little Vertical Junkie Masterclass. I thought for this week I'm going to do something a little bit different, and we'd go through the Climbharder Reddit and just talk over some of the things that are on there. I haven't really had a look at much this week. I've been pretty time poor covering some clinical work. So rather than sit here and spend hours typing back replies to some of these, I thought I'd just do it in a bit of a video format. So we can talk through some of the questions that people are asking and maybe some of the top posts for this week. And I'll give my thoughts and opinions on them. Whether anyone cares to listen to those, that's completely up to you. But I just thought it's an easier format than typing answers to a lot of this stuff. So, and I can cover things in more detail. I can pull up pictures and pull up images from the internet to show people more accurately what I'm talking about, hopefully. So let's get into it. I won't do the Hangout thread for this week. We might go straight into the questions and injuries thread. Obviously, as a clinical climbing physio, one of my passions is climb-related injuries. So let's run through some of these ones. Let's see here what people are talking about. A couple of years ago, climbing less than a year, a physio buddy of mine jokingly said I had wings and put his fingers below my scapula. Didn't know what it meant, but now it's kind of clicked. He's got shoulder and elbow instability and injuries he thinks might be linked to his winged scapulas. Does anyone have any exercises? He's found a lot of videos, but they're not super simple to understand. So for a few stretches, he's going to work on scapular push-ups without much equipment that he has. Pull up bar, blah, 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 blah. Okay, so scapular winging, this is pretty common in athletes and non-athletes. Let's see if I can get a little bit of info in here. This is something I've pulled up before. I use this to show clients quite a bit. Wait for this little diagram to load. So winging scapulas can be from a bunch of issues. You can have issues with your nerve innervation of a few different muscles around the scapula, or you can have weakness or imbalance in some of the muscles in the scapula. Scapular dyskinesia, or like improper movement of the scapula, is something that physios sort of around 2010, they really jumped onto as a clinical concept. Kind of before the research was really at a point to say that it was pathologically relevant to a lot of shoulder issues. Since that point, physios are very quick to jump on board and say that people's shoulder blades and scapulas are not working properly. There's differences between the sides, or there's issues with how the scapulas move through functional range of motion. But the more we delve into this, the more we understand that scapular dyskinesia and scapular mechanics aren't nearly as simple as that. There's so much variation between a population and even between sides in a person, dominant, non-dominant. And that doesn't always mean that that's a pathological issue, or that's an issue that's creating symptoms or leads to other issues. A lot of the times, even with people with really bad sort of scapular mechanics, have quite stable shoulders. And there's some really interesting research that's kind of coming out that's sort of saying, if you don't tell clinicians whether someone has an injury or not, and you try and get them to identify if someone's got scapular dyskinesia or poor scapular movement, quite a low percentage of scapular issues will be diagnosed. Whereas if you get people to walk into a clinic, the same people with the same shoulder scapular mechanics, but you tell them there's a shoulder pathology, then 90% of those people, and I'm just pulling stats out from the air here, I can link to some of those studies, but 90% of those people actually get diagnosed as having scapular dyskinesia. So the fact that clinicians are actually looking for it, and if they look for it, they can find it. The scapula moves in a lot of different planes. So our scapula is our shoulder blade. You can see here with a bunch of muscles around it. When you lift the arm, the scapula is meant to sort of protract around the rib cage here, and that allows better range of motion in your glenohumeral joint here at the top. And then also when the shoulder wants to stabilize, a lot of the times it retracts back, locks up against the rib cage here, nice and flat, so that it provides a nice stable surface for people to load the upper limb. But that's a really basic overview. It's a complex movement pattern that uses a bunch of these muscles around the shoulder to actually rotate and manipulate the scapula. And a lot of times it doesn't work perfectly. You know, a lot of people have different adaptations depending on how they use the arm and what sports they perform. Okay. And it's not realistic that clinicians can sort of justify all of those differences and then say, you know, that's a pathological issue. But if someone has, like this question we go back to here, if someone has, you know, a winging scapula where usually this inferior tip of the scapula really lifts off the rib cage here. Okay, so that sort of lifts backwards. That's not great. You know, you're not going to be able to generate a stable surface for the glenohumeral joint to move off. One of the big culprits for that is usually this serratus anterior muscle here. So you can see it starts on the rib cage, it wraps around, and it sort of goes onto the anterior surface of the scapula, so like the inside of the scapula against the rib cage here. And it's a really good muscle that helps stabilize the scapula during load, and it also helps protract the scapula. So it moves the scapula around. I wish I could sort of move this arm. It helps, oh, maybe I can. Scapular protraction, you know. It's got to be a good video of this, right? Scapular protraction. I want kind of like an animated video if we can. Okay, so you can see here, for this to happen, the scapula has to actually shift forward against the rib cage and rotate around, ways you won't get this anterior movement. I sort of want to show scapular protraction. So scapular dyskinesia, it's this really key phrase everyone sort of jumps on about, but it's wing scapula. Oh, here's the thing on wing scapula alone. Let's see if we can just pick. So you can see here, usually on end of range internal rotation or external rotation or abduction, the scapula can do really weird things. That's a pretty, you know, that's not much of a wing scapula there. Maybe this will show it. Serratus Anterior, so they're talking about that being very important. The rhomboids, yes. Upper traps, lower traps, levator scap, all those muscles. Here you go. You know, so that's sort of retraction. Okay. So that wasn't showing serratus. That's showing serratus weakness. So the serratus does the opposite movement to this, and because it's weak, you can see a retraction and an elevation of the scapula because the serratus anterior sort of drags it protraction and a little bit of depression there as well. So you can see it's a complex sort of relationship between all these muscles. Yeah, okay, so you can sort of see what serratus anterior does in that one. All right. Cool. So you got serratus anterior. You also have your upper traps, which isn't shown in this. This is sort of taking out the trapezius, I assume. Upper traps, your middle traps, and your lower trap, which control the position and the rotation of the scapula. You got your rhomboids in here. You've even got your teres major and minor in there, and your, you know, your supraspinatus, which is this guy here, which is a big cause of rotator cuff injuries. You can see as it runs through this acromion under here, there's a big bursa under there as well. If we have issues with the scapula, you can get impingement in there. You can get all kinds of issues with this guy. But this supraspinatus, this is one a lot of you guys that are getting rotator cuff issues. This tends to be the one that gets degenerative the quickest in our rotator cuff. And it's that sort of abduction, you know, when you're lifting the arm up sideways, you feel a little bit of weakness around that 90 degrees, gets a little bit worse with the thumb turned down traditionally. And that can be because of the way your scapula moves, but it also is usually due to, you know, poor training habits, repetitive stress, repetitive behaviors, a lot of upper, like overhead positions, repetitive movements up there tends to put a lot of stress and overload on the supraspinatus, and then the tendon over here starts to get degenerative. So yeah, if this serratus anterior is weak, you know, this posterior and the lower traps aren't great as well. This inferior sort of posterior section of the scapula can wing up. It doesn't give you a stable base of movement to then do overhead positions, you know, this wing scapula. So we do want to do some serratus anterior strengthening work, and some lower trap strengthening work will help to reduce that and improve the stability of the shoulder. We talk about, you know, kinetic chain in climbing is really, really important. So, you know, kinetic chain is everything from the fingertips all the way through wrist stability, elbow stability, and making sure there's no pathology in the elbow that creates weakness further down the chain. good stability in the shoulder, strong rotator cuff, strong delt, strong posterior shoulder, strong capsule, is a big thing as well. A lot of people have degeneration of the glenoid and the glenoid rim in here, which, they might not have had an anterior dislocation or something that severe, but they've got instability there. They might need to do some extra work to compensate in the shoulder. And then also part of that kinetic chain is, scapular strength, even into sort of thoracic spine mobility, so that you can get enough extension of thoracic spine to reach above the head quite well. So it goes all the way up and down is really important. So if this guy's got winging scapulars, that's probably his low hanging fruit, this shoulder and scapular mechanics and getting stability and strength in that. So he said he was doing some exercises. If I spend this long on every question, we're going to be here for weeks. That's all right. Maybe we'll go for half an hour and then we'll just call it quits. So some really good exercises. He's going to want to be doing Serratus Anterior work, which is basically like, you're holding the arm and you're protracting it forward and bringing it back and keeping that movement nice and controlled. When you're protracting it forward, you really want to engage that Serratus Anterior, but you want to do it without the shoulder lifting up. Okay, so some people, because they've got weakness in that Serratus Anterior, when they try to engage it, they get a little bit more co-contraction around the unstable scapula, and the upper traps are usually overactive in these people as well that have, weak lower traps and weak Serratus Anterior. They have a really sort of hyperactive levator scap and a really hyperactive upper traps, and that causes some postural issues as well. So I wouldn't be surprised if this guy maybe gets recurrent neck pain. Maybe he's got a job where he's in a seated position for a long time as well. But I can't assume anything. I'd have to talk to him. But doing that protraction and keeping the shoulder depressed while it's doing it is going to be really, really important. So you can do that in like a one-arm push-up position, and you just keep the arm straight and you just do a protraction exercise. You can do that as like a one-arm bench and protraction exercise. You can even do it as like a military press or a strict press, and you encourage that protraction and retraction. And then you want to do the lower traps is probably going to be really important as well. Serratus weakness and lower trap issues tend to go the same way. So we'll go back to our picture here. Our lower trap, these are rhomboids. Our lower trapezius sort of goes from your spine up to the inferior portion of your scapula there. So it sort of comes up like this. And it's important to get them strong as well. Now, they're a retraction and a depression when they activate, and a little bit of, rotation of the scapula, but we won't worry about that. So basically, that's all those things, when you're doing bent over rows and they're telling you to squeeze the scapulas together, hold that position while you're doing the row. Okay. And there's countless exercises where you can, hold that retraction position. The pale-off press is a good one, holding retraction depression while you're doing pale-off press, which is like a sidewards resistance, and you're doing this kind of movement, is really good for shoulder stability and scapular positioning as well. But just really trying to engage that sort of retraction when you're doing some exercises. Now, this is all strengthening work. We used to think that you want shoulder retraction for like everything, but that's not accurate either. It's like climbing, you want to be able to apply a technique to solve a given problem. And in the scapula, you want it to be able to position and stabilize itself where it needs to be to allow enough rotation and protraction so that you can get range of motion, but then also so that it can squish and squash against the rib cage and become a stable element as well, and get good contraction between all the muscles that surround it, okay, because they're all very important. So I encourage this guy to do some lower traps work as well, and some scapular positioning stuff. And then you can practice that as you progress range of motion as well. You're doing rows quite in a range for the shoulder. You can start doing some band work, and you're focusing on retraction and protraction while you're doing that band work. Okay, it'll be a lot harder with the shoulder sort of protracted out. It gives a lot less stability. It forces the rotator cuff to work really, really well. But getting that retraction and getting the lower traps involved in that movement's really important as well. And this guy should really start to learn some of this stuff and just understand, the basic mechanics of the shoulder and what he wants from his shoulder, and then he can create his own program to kind of target that. You don't want it to be all serratus work. A really comprehensive shoulder problem is really important. A lot of our athletes, we encourage them to do, start with these rehabby kind of exercises, but then turn them into functional shoulder exercises, you know. So doing a one arm dead hang scapular retraction or scapular pull up, it would be a really good progression for this guy to build strength and support around his shoulder and around his scapulars in a climbing functional specific way. So yeah, a lot to talk on about shoulders. I love helping shoulders, you know, helping people work on their shoulders as climbers. I tend to find that when we do a physical functional assessment, we run through a lot of people. This is a low hanging fruit for them, getting really strong bomber shoulders. A lot of people trying to hang off one arm and they're spinning all over the place and they can't get retraction and stability in the shoulder and the scapula to actually engage. A lot of people sort of think their bicep isn't strong enough and their lats aren't strong enough when they're doing a one arm pull up. But a lot of times it's not having enough shoulder strength to actually engage the shoulder. So those muscles have a stable base to pull off. You know, if you've got an unstable shoulder and you're trying to activate lats and bicep, they're not having a stable surface to even engage and start that movement in the first place. And so you're just not going to get good activation out of them. Maybe you've got a lot of strength. Maybe, you know, you can do a 90 kilo one arm row and you're thinking, you know, I should be able to do a one arm pull up. Maybe shoulder stability and shoulder strength is your weakness. Okay, so some people giving him, there's no such thing as shoulder instability. The science opposes it. Yes and no. Maybe this guy's trying to touch on the whole fact that shoulder dyskinesia is, you know, not what it was thought. There is such a thing as shoulder instability when we talk about people who have an anterior dislocation who have Bankart lesions and Hill-Sachs deformities and all this stuff. You know, those people have shoulder instability. That's a different issue. So could you elaborate? So this guy's really interested about that shoulder instability thing. We kind of just touched on it there. Scapular pull-ups and push-up dips, rolling shoulders forward, dumbbell raises. Yeah, I mean, all this stuff is really good shoulder work and good things that climbers can put into a supplemental strength program. Off season's a great time to, you know, pick this. If you got shoulder issues, work through a progressive loading program for shoulder and then make it complex dynamic, do protraction, do retraction, you know, do everything there. Due to lockdown, very limited option to climb. This guy's using a minimal edge protocol, which is a hangboard protocol. Keep fingers strong. He's also doing some supplemental. Do we have a question here? He gets pump sets in very, very fast. Well, doing minimal edge stuff's not going to be helping you with that. Prepare better for outdoor season. What is the best way to train endurance, possibly on a hangboard? Yeah, look, repeaters, you're definitely going to get more of a energy system improvement than you are on a minimal edge. When you climb, possibly, are there any training exercises you might schedule? You know, hangboard is just a tool, and you can. I always talk about hangboarding as, you know, you've got a spectrum of things you can train on it, down from like a 7-second max hang, which is more a nervous system and recruitment adaptation. And then as you switch to repeaters, you're getting more of an energy system, changes a little bit more hypertrophy work, a little bit more volume in that. And yeah, you're going to get a little bit more target on some of those energy systems which have, you know, recovery involved in them. And you're changing over from, you know, an anaerobic to an aerobic and all the different processes involved in that. You're going to be training more with a repeater block. I mean, the simple way for this guy is just, you know, do some multi-rep repeaters, you know, and bump those repeaters up to, you know, 10, 15 reps of a really low low percentage of his maximal repeater. Okay, so if his MVC, you know, if his hanging body weight plus 30%, you know, drop that down to maybe 50% of body weight and do 10 fives times by 12. I mean, I think he knows his answer already. Yes, swap to repeaters, decrease the load, increase the volume. You're going to get a lot more endurance out of that. I like to do 10 fives as well, rather than like 7 threes. 7 threes, I just find that 3 seconds, if I'm doing repeaters, is not enough time to kind of even like, you know, get a bit of chalk on your hand or shake them out or reposition the hold. So personally, I like 10 fives, but I mean, there's so many protocols out there, but definitely change. So this guy's freaking magrum. He's a strong climber. He's always on here. Yeah, so this is another option. You could do changing holds using a band, or even having one foot on the ground to simulate long duration climbing. You can do on-off stuff. You could hang a hangboard, and this is something I've done before. Hang a hangboard underneath that hangboard, do one toe on a little rail, and then you're just doing like campus walks between the hangboards, to sort of simulate one arm on, one arm off. Depends what this guy's aerobic sort of tolerances as well. Maybe doing some arcing stuff, some aerobic capacity stuff could be good for him. It really depends on what his exercise and his sports tolerance is for climbing. If he's been climbing 10 years, then arcing is probably not, as beneficial, but it doesn't sound like that to me. I have recurring bicep tendonitis in both arms. So if you have recurring tendonitis, there's a good chance it's not tendonitis. We've moved on from that term. This is something that I really gets under my skin, this whole tendonitis thing, because tendonitis, itis means inflammation in medical lingo. And when people say things like bicep or bicep tendonitis, they're inferring that inflammation is a primary driver of the pathology. And in 99 times out of 100 for climbers, inflammation is not the primary issue to be tackling. It also suggests rest, like inflammation, people think rest, ice, compression, elevation. We've moved on. We've got a bunch of different acronyms for different things that involve, some kind of exposure to load now, which is great. But, tendonitis, people think inflammation, I've overdone it, I'm going to rest and that's going to solve my issue. But if this is not tendonitis, this is a different kind of tendinopathy, more likely tendinosis, which is a chronic degenerative state of disrepair in the tendon. Rest is not going to do anything for you because tendons respond to load. Load's the only thing which changes tendon. And if you have really poor training habits and over years and years of poor healing rates and poor recovery of your tendons, and you get these degenerative changes, you get reduction in collagen density, you get neovascularization in your tendon, you get malalignment and of type 3 collagen in your tendon, you get all these negative changes that affect the strength and the mechanics of your tendon. I'd love to tell you where pain in that tendon comes from, but we don't have a solid grasp on that. We used to think we did, but it's still up in the air a little bit. But with that point aside, that's very different than just, I need to rest a little bit and that's going to fix my inflamed tendon. There's a deeper discussion that we have to talk about there about training habits and rest and recovery, nutrition, all those things which you have to get right if you want good tendon healing and progression of tendon strength over time. So getting back to the question, we didn't even get 5 words in the question before I got sidetracked. Rested for a week, my right arm to be very painful, came back, my left arm feeling the exact same way after warming up. What do I need to do to heal and to prevent these injuries from returning? I feel like I'm stagnating, how my schedule climbing is suffering. I feel weak. I climb V7 if that helps. So that doesn't really help. What helps is your training history and your training habits and your climbing history and your climbing habits. Do you climb more than 4 days a week? Do you climb more than 4 days in a row? What's your nutrition, your rest like? What's your age like? It's harder to get recovery in your tendon as you get older, and we get changes in our tendons as we get older as well. So you have to adapt your programs and you have to take those things into account. So yeah, your training history is going to impact more than I climb V7 if that helps. Do a bicep curl and 90-degree lock off 10 seconds, make it heavy but not so it hurts. Do it for your session, do 5 sets, turn them into Harriman curl position. You find this, my boat is the same thing. So what this guy is indicating is doing some isometric loading. He's got his timings all wrong if this is a tendinopathy issue. Yeah, I mean, this guy's sort of saying you want to do some progressive loading, but he's not really, diagnosing what's going on here. Bicep tendonitis in both arms. So people always come to me and say, I've got bicep tendonitis, but a lot of the times it's not that. Sometimes it's your pronator teres having issues, and people thought that it's bicep. And we've got multiple different biceps as well. You've got brachialis, brachioradialis, and biceps brachii are the main ones. The flexi elbow, and then you get pronator teres as well. So it's really important that you diagnose what is causing the issue here before you go into trying to solve it. But hey, welcome to solving things on Reddit. So this guy is talking about doing some progressive loading. 90-degree lock off, that's good, because a lot of times bicep tendonitis, part of it is tendonitis. Now I'm doing it. Biceps tendinopathy is partly a compression in a lock off position. It causes issues with that. But a lot of the times when people have that as well, it's not bicep, it's pronator teres, but let's not go there. But one of the good places to start with any kind of tendinopathy is long duration loading. So isometric loading, yep, tick, he's got that one. But the duration you want to actually make up to about 40, 50 seconds. One of the ways you've got a tendon issue is if you do like 5 sets of 40-second holds in an isometric position that loads the specific tendon that you're talking about, your pain response should go down. So let's say someone's having bicep tendonitis and we get them to do 5 pull-ups, and then they say, okay, my pain's like a 4 out of 10 doing that. I can feel that bicep being a little bit painful on loading. And then we do some isometric loading of that tendon, long duration, 40 to 50 seconds. We do 4 or 5 reps of that. And then we get them to repeat that test. And okay, all right, we're going to do those same pull-ups again and tell me how your pain's changed. Now, you'd think after loading the tendon, we've stirred it up. People think this itis, this inflammatory thing, we're poking the bear. But that's just not how tendons work. What should happen if it's a true tendon issue is the pain actually goes down, and that indicates tendinopathy for us. And then that also gives us some direction for loading as well. Now, there can be other factors going on. A lot of times when people have really severe tendon issues, they've got changes in their nervous system in terms of how they tolerate and how they relate to pain. They might have, inflammatory conditions around that issue as well. If they've got improper loading mechanics or they've got other overtraining, they might have like a bursitis in there, or they might have some other soft tissue issue going on, which can confuse that. And that's where maybe rest is a good thing. Maybe you rest for 2 weeks to settle those soft tissue injuries down surrounding that tendon, and then we test the tendon, we do some tendon loading strategies, we see how the tendon responds to that, and then we can actually tell you what's going on in the tendon, and we can give you the appropriate progressive loading protocol to do that. This guy, he's going into some isometric stuff, but it's also important when you have tendon loading. One of the reasons we do isometrics in sort of mid-range is because it eliminates a lot of compression in the tendons, which is one of the things which causes issues in a tendinopathy. It also tends to be a more tolerable load. There's less sort of sliding of the tendons and change in the structures, and you've got other things going on. It's less impactful on that. So we do these isometrics to start with. They tend to tolerate well, but I'd be lying to you if we said exactly why people tolerate that well. That's our assumptions about the whole compression issues. But then you have to progress those into a sport-specific progressive loading program as well. You have to start to introduce compression and movement. And then for climbing as well, you have to start to incorporate a little bit of short duration loading. You have to incorporate a little bit of energy release work as well, because when you're doing campusing and things like that, there's elements of energy release and energy absorption in our upper limb tendons, even though they're positional tendons, and this is another complex issue, that we have different types of tendons in the body. We've got these energy loading tendons like the Achilles in the calf and the patella tendon in the knee, and the properties of those tendons is slightly different to the tendons in the upper limb. The tendons in the upper limb are more positional tendons, so that creates issues when we try to extrapolate some of these pathological issues that go on in like patella and Achilles tendon, because that's where all the research is, and we try and move it across to positional tendons, which are like these fine motor control tendons that we have in our fingers. They're not meant to be one arm 6 mil edge hanging tolerant tendons, but we turn them into that over time as climbers. We build density, we build strength, we build all these crazy adaptations to try and turn them into that. So we have to keep in mind that they're positional So in doing that, we're trying to get a positional tendon to take energy storage loads, and when people have tendon issues, it's important to progress them back to that. Whereas what will happen, they do these isometrics, the symptoms start to drop, and they think, I can get back to climbing now. My symptoms are 1 out of 10, or they're not too great, and then they start doing some harder limit stuff, and they start introducing compressive load and energy storage, energy dissipation in their tendons, and then their symptoms come back again. So this guy, the fact that it's recurring, if you do this, it might feel better for a little bit, but it's probably going to stay recurring. So go talk to a really good climbing physio, get some progressive exercise loading programs going. It'll take you, if this has been going on for a year or two, it might take you 3-4 months to work through that program. And that doesn't mean you can't climb during that. You'll definitely have to drop your intensity down, drop your volume down a little bit, especially as you start your loading program, because a good tendon loading program, has a lot of sort of, you're doing it very regularly, sort of twice a day at the start. Probably the first couple of weeks, you're going to be doing this loading program twice a day to start managing the changes in that tendon, and to look at, structural change in the tendon. And if you're climbing a lot, that's going to be too much volume, and it's going to get in the way of that a little bit as well. So you can definitely still climb a couple times a week, just really easy stuff. Focus on technical adaptation, maybe do some aerobic capacity stuff, will be fine. And I mean, aerobic capacity stuff's a long duration load for tendons anyway. So that's going to, build a little bit of elasticity into your tendons, and it's going to be healthy for them. So if you're substituting out one of your rehab sessions for an aerobic capacity session, or a low intensity session, that's probably absolutely fine, and it's going to keep you sane and stable while you're doing these things. So this guy, best is control climbing and volume and intensity, so it doesn't make it worse. Rehab program, progressively load, so people are starting to get switched on, which is good. Eccentric curls, people used to assume eccentric was the really beneficial. A lot of the early tendon research was on eccentric loading programs. And then we've recently found, it doesn't matter if it's eccentric, concentric. It's the slow and long duration, which is the most important part. So that's fine though, as long as you're doing some loading. That's going to be better than resting. Stretching, massage. Massage doesn't change tendons. That's fine though. I won't get into that. You don't want me to rant on sun worshipping and other clinical interventions that maybe do or don't do anything. Stretching's fine. That's good as well. Don't overdo it. So yeah, don't overdo it while climbing. So understanding your training volume and your climbing volume is number one. Volume management. This is something that elite sports tackled a while back in terms of volume management, and they went a bit crazy with it, and then it got really controversial. But in climbing, we're loading positional tendons in the upper limb, so we have to give a lot of food for thought on what our training looks like, what our volume and our climbing intensity looks like, and trying to work out where your own tolerance to recovery and recuperation is. You've got a lot of yellow flags that pop up before people go down tendinopathy, or they go down shoulder dislocations and all these other things that happen. And people tend to ignore those yellow flags, but if you sort of accept them and delve into them and look at them, and then adapt your training program and your climbing sort of program to take them into account and sort of address them, then you're going to be so far ahead of probably 99% of the people that post in this thread. Compartment syndrome in the forearms. Get back to climbing too quickly. Has anyone experienced or know someone who has this? Would love some advice. Yeah, absolutely. Compartment syndrome, basically, for those who don't know, is where you get hypertrophy of the forearm and it starts to occlude blood flow, and you got other issues there. It can happen in people who are really prone to building bulk and building muscle. Genetically, some people will tend to, have a more stout nature than others, and that's fine. I did have a friend, hey Johan, if you're listening to this, he went through this, he got this compartment syndrome in his arm, and we tried all kinds of different things to mitigate it. But in the end, he had to get a surgical fascial release to try and sort of break up some of the tissue and adhesions and things that he'd developed over years and years and years of climbing in his forearms. If you develop this, I mean, I'd be questioning whether it's compartment syndrome after trying to get back into climbing too quickly. Maybe you've actually got some acute soft tissue injury in there and it's feeling like compartment syndrome, because this usually comes from, overtraining over a long period of time, people who have a tendency to get hypertrophy, and you might have some other vascular issues, or you might have some soft tissue changes, poor sort of changes in the arm that help or don't help blood flow, that occlude blood flow. I mean, you could have some other random things going on as well, like maybe sometimes compartment syndrome is actually neurological burning pain, ulnar nerve entrapment syndrome, or cubital fossa syndrome, or other things that actually feel like a compartment syndrome. So, I mean, you don't see too many true compartment syndromes these days in climbers. I've seen a few, but yeah, go get that checked out clinically. You can also do get someone to test blood flow on the upper limb, make sure you're not having any arterial restriction or other health issues, which this might actually be a secondary symptom of. I'm doing 3-2-2-1 hangboarding. During minimum leg reach, so I do 3-finger drag or just half cramp. 3-finger drag feels a little bit weird. I'm sure I should keep this going. Yeah, I mean, Freaking Magnum's pretty much covered this pretty well, it seems like. I'll just read his response. There is a skill aspect to holding really small edges. Yeah, so minimum edge work, it's not so much like an energy system change. It's a little bit of probably a max strength stimulus and nervous system recruitment stimulus, but it's a skill as well, and you get adaptations to the soft tissue at the end of the finger, which help you hold on to those sort of small edges. You get changes in the way that you use your wrist to actually really engage on those small edges. You get really good extension and strength in the wrist to actually engage those. So you get other changes. And if it's a weakness, if your project has a lot of small edges and you have a difficult time holding on to small edges, pick it as a low-hanging fruit and add it into your program for sure. 3-finger drag versus your half crimp. I personally think you should do blocks of different hold types. If you're really strong in half crimp, but 3-finger drag or more open hand is difficult for you, do some training blocks to address it. Absolutely. Coming out the 2 weeks of a program and just 3-2-2-1. So I think this 3-2-2-1 hangboarding is probably doing, a couple of weeks for minimum edge, a couple of weeks on repeaters, a couple of weeks on max hangs, and maybe this is who knows. Could be a deload week, or it could be a different protocol altogether. I'm not a huge fan of that personally. From my sort of own thoughts on hangboarding, I like people to stick to a single protocol for a block, like a 4 to 6 week block, and you can change grip types within that, but stick to a repeater session for 4 to 6 weeks, or stick to a max hang session. The reason for me is that it takes time for the body to gain adaptations to a stimulus. 4 to 6 weeks is a really good time to getting nervous system changes, or getting a little bit of hypertrophy and energy system changes from the hangboarding. If you change up protocols too often, I think you almost get the effect of like an undulating program, where you get a little bit of confusion between the adaptations, which doesn't, it's not a huge deal, but it doesn't optimize the benefits you're getting from that. And something like hangboarding is so easy to, program in apart from your climbing stimulus, and to make it a really specific and direct stimulus to target an adaptation that you're weak on. So why would you kind of muddle that up by changing protocols really, really quickly? If you're doing some training in the gym and you're climbing outdoors, it's hard to not cross-train different energy systems, and you don't want to waste too much time and effort worrying about that unless you've got a really structured program. But for something like hangboarding, it's really easy to stick to a stimulus and get sort of the most optimal results and adaptations from that. So yeah, 3-2-2-1. I mean, for the most part, if someone's got a program that stimulates them and they enjoy, and they're sticking to it, and they're over a long period of time, if this guy really enjoys 3-2-2-1 because it changes up quick enough that it keeps him interested, and he does that program a couple of times a year in blocks, and he does that for like 4 or 5 years of his climbing career, that's fantastic. And that's, that's just doing the simple things right, and that's the most important thing. if he changed to a 6-week program and he found his compliance was really bad because it was boring and it's the same thing for 6 weeks, then yeah, fine. 3, 2, 2, 1. I wouldn't have too many gripes over, I guess. Am I just contradicting myself? Heel bursitis. Hurts like hell when wearing my climbing shoes. I'm climb with them on. It's the same experience and recovered from. Interesting to hearing what helped. What's the aggravating activity there? Seems really interesting. Is he a boulder and you're falling down onto hard ground or onto mats repetitively? Heel bursitis is not something sort of super common with climbers. Are you cross training? I wonder if he's doing a lot of running and he's actually got like an Achilles insertional issue and it's kind of feeling like a heel bursitis. And maybe when he's climbing, standing on the carbs a lot, maybe you've got the Achilles comes down the foot. Achilles. Achilles tendon. Let's pick some random images. Okay, so you can see here you got the Achilles tendon comes down and it sort of goes through and it actually does connect in and sort of travel along and turn into this plantar fascia ligament. All right, it does insert in the calcaneus, but it's all one kinetic chain there. So I wonder if he's having some issues around here from some Achilles tendon and some plantar fasciitis sort of issues. Yeah, it'd be hard to say. I need more information for that question, I think. No one's replied to that, so I'll reply to that today just to give him something to some questions to think about. Praised my pulley a few weeks ago. I wonder if praising pulleys is a really good way to keep them healthy. Like we all feel good when someone praises us, right? Probably increase the partial tear after some climbing after that. Have my first outdoor trip in 2 weeks. I want to die. Okay, so this is what we talk about when people, get so caught up in a sport that it really affects their mental health. And injuries, come on, we're all addicted to climbing. Injuries do affect our mental health massively. And this is why, one of the first things I address when a climber has to go into surgery or a climber has to, have a long rest period due to a traumatic injury or other issues going around. I try and encourage them to find other things to keep motivated or keep productive or to focus their energy because it's really easy for them to get into this really negative headspace. And this isn't just climbers, this is a lot of athletes in general. I used to work with a lot of different athletes from different sports and trying to turn that rest period into a really positive interaction. Maybe they're using it to upskill their knowledge, or maybe they can plan out training blocks for the future or do some research to improve their knowledge on training or injury management or something else in their sport, or even, become someone who sort of produces some content around the sport, like just something to keep them positive, because this is not great. So he's got his first outdoor trip in 2 weeks. This happened to me a long time ago. I was climbing for a trip down the Blueies, training for a trip, and I blew a pulley out a couple of weeks before the trip. And I rested it for a couple of weeks, and then basically I just taped the shit out of it and climbed very easily anyway. I guess it depends how bad it is. People saying don't go on the trip, play the long game, reduce climbing volume. A month after the trip before it could hang. I'm not going to push it. Going to be strict with open hand. Okay, I mean, like any pulley injury, yeah, the more you can stick to open hand, the more you're going to have less issues with it. It's 2 weeks to his trip. I'd probably recommend that he rests for that 2 weeks. Just give that pulley enough time to develop some scar tissue and some sort of early healing stages as possible. If you have an acute injury like an acute pulley tear and you're climbing on it too soon, like in that first week or two, all you're doing is delaying those initial stages of sort of laying down some collagen to start turning that into more mature collagen and to building up strength. So that sort of scar tissue process, I guess, in the ligament or in the annular ligament there. And then that's probably going to give him the best trip. If it was me, let's be realistic, I'd probably want to still go on the trip. I'd just completely rest it for 2 weeks and then, tape it up really well. I'd get a thermoplastic splint made up, quite a tight, probably I'd downsize it more than I'd recommend for clients. Thermoplastic splint, And then I'd be using that thermoplastic splint with some buddy taping as well, just to take as much load off that as possible. I'd be freaking wrapping the whole finger up. And then, yes, trying to stay open hand, trying to just stay on really low intensity climbing, really well below his limit. Definitely don't do any limit bouldering or anything like that. Go do some easy multis, have a good time, still have fun with your friends, support them, encourage them on their projects for the trip. But yeah, I mean, if it's only a partial tear, something, if it's like a grade 1 tear or something like that, in 2 weeks, if you're taping it up with a thermoplastic splint, keeping it overhand, keeping it easy, you'll probably be all right. This guy, similar injury. Yeah, acute management early on is important. Contrast baths and things like that. I'm not so sure about, because you actually want those early stage healing processes to take place. So if you're icing an acute injury for 2 weeks, you're actually slowing down the recovery of that injury. Here we go. We're almost down here. Anybody ever had issues of general fingers inflammation? Gym reopened 2 weeks ago and I really climbed too much, too hard, too fast. This is really common at the moment. People coming back from COVID assuming that they're kind of where they were when they left off, and they're, oh, my tea is so cold. Oh, still pretty good though. It's got monk fruit sweetener in it. Yeah, get onto that. That's really good stuff. Since then, tenderness and sensitivity in his front 3 fingers of both hands. So this is just a really common thing about overdoing it too soon, too early. Tendons and a lot of the soft tissue in the body doesn't respond to change well. Okay, you need to give it time to formulate adaptation. So getting back in the gym and climbing as hard as you can because you're super stoked, and we've all done that. We've all done this recently with the gyms being closed and then reopening. Isn't a good idea, and it's going to lead you down to the path of getting some acute injuries. So when you are getting back in the gym, you can go in plenty of times. Just modulate your intensity, like do a harder session, do a couple of easier sessions, expose yourself to different stimulus, different types of climbs in the gym. And just build it up slowly, and if your gym's opening in 2 weeks or 3 weeks, maybe start doing some really low sub-maximal repeaters on a hangboard, get into your regular gym and do some body weight stuff, get into some chin-ups, and just sort of prep your body to getting back into that. Because I think most of the online sessions I've done in the last probably month or two coming out of the UK and America have been people basically going balls to the wall the second their gym's opened, and then they've come in with a climbing related injury. So freaking amazing, man, you've been good this week, mate, getting in and helping out people in here. The way the gym holds flex. So obviously he's been climbing outside a lot. Climbing outside is very different to climbing in a gym. In a gym, people tend to like way overdo it because they've got access to a lot of boulders in a small space. It's a comfortable environment. They're usually only 1 or 2 or 3 people working on that boulder. Whereas when you're outdoors, you're walking between boulder problems, you're taking a lot more rest because there's a lot more things going on in the environment. You're having lunch and you're chilling out and you're bouldering over an entire day. Whereas when people are climbing in the gym, they tend to do that full volume in like 2 hours, until they're completely smashed. And that's the difference. So I'm not sure, mate, if it's the way the holds flex that does a number on you. He has stiffness. Yeah, so I did a shitload more than I would have done. So he knows this. He's just looking for someone to reiterate it back to him, which is, I mean, it's half my job as a physio. People know what's going on. Need to ease up. Fingers are just now recovering from the same thing. Took a week off and worked the antagonist muscles. Feels a lot better now. So again, this guy just moderating volume a little bit. So awesome. Well, that's all the questions and injuries in the thread. We won't get into this. I think we've done this long enough. So I'll just leave that there. There's lots of good. I did click on this before. I was curious. So this guy broke my wrist. Ways I can still ways I can still train. This will be good. Broke his wrist snowboarding. Man, there's so many skiing and snowboarding injuries since I've started working with people in the UK and Canada. So he can't put weight on the hand. Obviously, he can't train, or he's going to be overcompensating with a broken wrist. He's been doing one arm hangs, assuming on the other arm. Working on core and stuff as well. I love working on stuff, stuffing my face. Is there anything else I should be doing with my good arm so I'll be able to overcompensate when I can start climbing again? Should I sandpaper my fingers that are in the cast to try and maintain skin? Look, dude, yeah. Personally, I wouldn't worry about that. Gosh, man, you got a fractured wrist. You're going in for surgery. Just lighten up a little bit. Get through the surgery and see how it comes out of it. The surgeon will give you a protocol to follow post-surgery, and physios should get you on board as well. Very quickly, they'll be getting you to do range of motion for the wrist, and then starting to build some progressional strength and conditioning back into that wrist as well. So the really important thing when you get back is going to be getting stability and strength back into the wrist in a slow, progressive way. He's putting a screw in. Screws can be an issue around the wrist. It's such a complex structure, and it's small for the amount of tendons and ligaments and all the carpal bones in the wrist. It's complex, and there's a lot going on there. So when you start introducing external fixations, or sorry, internal fixations, we do see some issues, especially in people getting back to complex movement and complex sport of getting issues with the wrist, because the internal fixations can change the mechanics, or they can put compressional load on structures. So I'd be very careful, slowly progressing and understanding what your wrist can tolerate when you get back into it. But in terms of ways you can still train, yeah, you can do stuff with the other arm. You can do core. You can do some general gym work. You can do bar work. You can do, yeah, there's tons of stuff you can do with only one arm. Climbing, I mean, there's even climbing related stuff you can do. You can get on the wall, do some slab climbing with the one arm. There's one of the drills we do is remove a limb, where you climb and remove a limb, and it teaches you how to get your weight over your feet and things like that. So there's plenty you can do. I'll just be a bit cautious if you've got a week or a wrist that's just come out of surgery. You don't want to be accidentally falling over in the gym and putting pressure on it. So they'll probably have a splint and a brace you can wear just to keep it protected and safe while you're doing other things. But just keep active is probably a good thing. Good time to do some cardio, do some cross training, some other sports that you enjoy. So be careful as you ramp back up. I fell into bad humans, assuming I could dig what I could do before the break, and still haven't gotten out of them. So this guy, exactly what I was talking about, he went back to really complex movements too quickly, and he ended up having issues with his wrist. 2018 studies showed training the good arm may help to prevent atrophy. I think I've read this one. I mean, this isn't a study. Let's actually have a look at the study. Increased wrist flexor strength in the non-immobilized limb and in the immobilized limb. Training -2.4 versus the control group -21.6. So that's pretty good. How many people were in this? 16 participants. That's not great. So this is kind of saying that doing some strength and conditioning can help retain muscle mass in the immobile limb. And absolutely, if you're staying active, if you've got, like, I've got a client at the moment with an ACL issue, fractures, upper limb dislocations, stuff like that. Staying active is really, really important, because the hormones and the testosterone and sort of the all the processes that go on when you work out, they aren't specific always to the tissue that you're working out. And this is one reason why people recommend doing like a strength and conditioning workout for the lower limbs or for the body, and then doing your hangboarding after, because you've got all these hormones that release that help build muscle recovery and collagen synthesis and all these things, and they're non-specific, so they're floating around the body affecting different things. And if you can give them a little bit of direction by doing an extra stimulus, particularly with the tendons, and that's good, and you're utilizing those extra things that are in the bloodstream, but it's also going to help immobilized. If this arm's immobilized, you're still going to get some of those hormones being absorbed by the soft tissue and the muscle bellies to build some or maintain some muscle strength and some muscular adaptations. I'm starting to slur my words. So that's interesting. I thought that was going to be different. I thought it was going to be like, you know, I've broken my wrist. Can I do muscle ups on it? You know, but pretty good. All right, we might leave it there, guys. I'm starting to wander. I hope you enjoyed this change on the masterclass. Went through some injury stuff. We talked about scapular mechanics. We talked about some tendon stuff. We talked about tendonitis not being tendonitis, but being tendinosis or some other form of tendinopathy. So yeah, hopefully that was interesting. And I'm just going to cut it there. Have a good afternoon. How do I stop share? Yep, still recording.